Do no harm. On Mother's Day in 2014, Hilda, my patient and friend, died. I knew we had done harm. At the age of 14, Hilda left Mexico, escaping poverty and violence. I met Hilda when she was in her mid-20s. She was a single mom with 2 little boys, but she was forced to face the brink of death every week. Hilda's kidneys had failed. You need your kidneys to live because they clean your blood. They filter your blood and remove excess fluid and toxins. Kidney treatment options include conservative management, kidney transplant, and dialysis. There are 2 forms of dialysis, peritoneal dialysis and hemodialysis. In hemodialysis, a machine filters the blood and removes excess fluid and toxins for 4 hours, and it's scheduled 3 times per week. In our country, US citizens have access to healthcare coverage for all kidney treatment options because of a Medicare entitlement program. Hilda was undocumented, and because of state and federal policies, she had no healthcare coverage for dialysis or any other kidney treatment option. Instead, she was forced to wait for her symptoms to accumulate over 7 days before we could step in with life-saving dialysis. She was admitted to our hospital once a week. Our hospital medicine team knew her well. I immediately connected with Hilda because our lives were parallel. We both grew up in poverty. English was our second language. We were both in our mid-20s, and we were both mothers to 2 small children. My parents came to this country just a few days before I was born, so I had US citizenship. I pursued a medical degree, and I had access to quality health care. Hilda, on the other hand, was forced to end her education early. She married her mother's friend at the age of 13, and she was forced to face the brink of death because she had no health care coverage. Initially, Hilda was my patient, but over time, we became friends. I stood by and watched Hilda's health deteriorate. Her boys watched too. Her boys were home one of the times that her heart stopped. They watched her receive CPR. After that experience, her boys did not want to leave her side. In fact, they stayed in the hospital each week when she was admitted and missed school. Hilda knew that her days were numbered, and she knew that she and her boys could not continue to live this way. And so she made a very difficult decision. Hilda decided that she would find adoptive parents for her boys, and she would stop emergency dialysis. She died on Mother's Day in 2014. Our hospital medicine team was taking care of 70 patients just like Hilda. They all came to our hospital once a week after 7 days of accumulating symptoms for dialysis. I could not continue to provide this type of care. This was morally distressing. Do no harm. How many of you face moral distress because policies in your clinic or at the state and federal level push you to do harm? How many of you feel powerless because of racist laws, unjust laws? It's not the number of hours we're asked to work. It's not even the number of patients we're asked to see. It is because we are working in a broken health system and our patients lack safeguards. We can't always act in the way that our ethics demand or our moral compass leads us, but we have choices. I had a choice. I had been a full-time clinician for 6 years and had no research experience, but it was in this moment that I decided to fully transition to research for the sole purpose of changing health policy. For 4 years, my team conducted extensive qualitative and quantitative research. We looked at costs. It cost the state $20,000 per person per month to provide emergency dialysis because of emergency services and hospital services. It cost the state $5,500 to provide regular dialysis. That's 4 times the cost. We also looked at mortality, and we found that compared to people who receive regular dialysis, those who are forced to wait until they're near death to receive dialysis once a week have shorter lives. Mortality is 5 times worse at 1 year and 14 times worse at 5 years. We also looked at symptoms, and we asked patients about their experiences. When patients are forced to wait 7 days before they can receive dialysis, they're short of breath because fluid builds up in their lungs. They're nauseous, they're confused, their heart stops because toxins build up in their system. Patients talked about physical and psychosocial distress. They all had near-death experiences just like Hilda. One patient recalled a CPR experience and said, "I've had people pushing on me right here, my chest. I think it's happened 3 or 4 times, but I don't remember much, except that my family thought I was dead." We also talked to clinicians about their experiences providing emergency dialysis, and they described moral distress as a major factor in burnout. This is because they're forced to witness needless suffering and high mortality. And because they feel that they are propagating injustice, because the care that they're providing is based on immigration status and not on anything medical. One clinician said, "Emergency dialysis makes us feel very inhuman. We're torturing them." Another clinician said, "It's a strong message about how we see some patients. Some are worthy and some are not." Clinicians also talked about engaging in advocacy, changing the system, and this is one way they found reduced the moral distress that they felt. Engaging in changing the system to reduce that sense of powerlessness is real. We have choices. We can choose inaction and despair, or we can choose advocacy and hope. I chose to engage in advocacy, and I want to read these words because they are very important. The Code of Medical Ethics from the American Medical Association states, "In some cases, the law mandates conduct that is ethically unacceptable. When physicians believe a law violates ethical values or is unjust, they should work to change the law." This is our duty. In Hilda's case, state and federal policies prevented us from providing the right care and led to moral distress. Because I chose to engage in advocacy, I partnered with patients and their caregivers. I partnered with policymakers to understand the structural barriers that were challenging. I did not do this alone. I did this with my team. As a team, we better understood the structural challenges that were in the way and the ways to change this. As a team, we applied persistent pressure, and we successfully changed healthcare policy. I am here today to tell you that this is what choosing advocacy looks like in action. It looks like a team tackling structural barriers and making the impossible possible. Colorado became the 16th state to provide statewide access to dialysis healthcare coverage for undocumented immigrants. Since then, we've connected with people all over the country who are similarly interested in expanding access to care in their states. And I'm excited to share with you that there are now over 20 states that have expanded access to healthcare coverage for undocumented immigrants. I identified a law that was causing our patients harm and clinicians moral distress. I had the choice to continue acting against my values or to change the system. I chose to change the system, and I encourage you to change the system. When policies cause you to cause harm to your patients or lead to moral distress, you can change the system. Many of us are not trained in advocacy, but we can learn. We can build relationships, we can build coalitions, we can partner with policy stakeholders and learn from them. I'm excited for a future where clinicians engage in advocacy to eliminate structural racism. Every time I see these pictures of the boys, I am encouraged that we can together build a better future. Hilda's boys were adopted by amazing parents, Chris and Helen. Her boys attended school. Her oldest son graduated from high school and is in college. And every time I think of this experience and how it has increased my passion for research as a mechanism to change health equity, I think of Hilda. Will you join me in choosing advocacy?